Prashant, thank you very much. It's really a pleasure to be here. I come from the East Coast, born and raised there, Pakistani heritage, but being in California is awesome. And I think this is one of the best trips I've ever had, just because I've met so many amazing people. You know, I'm not used to being the dumbest guy in the room. I'm definitely in this room, I am. We have some outstanding, I've met some really brilliant people here, and it's been very, very fun for me to be here. I have a pretty easy job actually today. I'm just going to share some stories with you from the front lines, from the back office, and from the enterprise level health system. My name is Dr. Ghauri. I'm a practicing internist. I've seen the light, and I've now transitioned into integrative medicine, which is just a fascinating area in and of itself. And let me just start with my father. My father, about 5 years ago, had some chest pain. And it turned out that one of his arteries was blocked, and he was admitted to my service at my hospital. And I have a very important rule, which I'm sure Dr. Mukherjee has the same rule, that you never ever treat your parents. So my colleague, who's a fantastic internist himself, took care of my father. He got his catheterization. He came to the room. My dad is a really smart guy, engineer by background, and very with it, very engaged, and he was in the hospital for 3 or 4 days. On the day of discharge, his care went perfectly. On the day of discharge, my partner went to his room. He spent 45 minutes with my dad before he left. And I'm telling you, Dr. Mukherjee might confirm this, but that's very unusual for a doctor to spend that much time with a patient, especially on discharge. The doctors don't spend that much time. Any of you that have ever been in the hospital, hopefully none of you have, but and he's a fantastic intern. I know what he told him, and he gave him discharge instructions. My dad went home. Good. My dad called me the next morning, 9 a.m., says, "What am I supposed to do with this, and how do I do that?" And I'm like, "Did you hear what Dr. Mueller said?" And he said, "Yeah." I said, "Well, what about the discharge instructions?" He said, "What discharge instructions?" He had no idea that he got discharge instructions. And this is a very meticulous man, an accountant. He was an engineer, he became an accountant. And the point of telling you this story is that things happen in the hospital that are just unexplainable. And when you're in the hospital for 3 or 4 days, you don't really know what's going on sometimes, no matter how bright and how smart you are. And wouldn't it be great if we could have recorded that 45-minute interaction on video? Wouldn't that be awesome? Right? I mean, that'd be fantastic, right? There is a company out there that does that. What is the likelihood of us getting that product in our hospital? Anybody want to guess? 0. I don't know, maybe at your place? 0. Fantastic idea, but the sociology of what happens in our hospitals and in all of our healthcare settings, to be frank, is one of the reasons why we're in such deep trouble as an industry, as a healthcare industry. There's lots of things that prevent terrific work that was like that was just presented from actually making it to the bedside. And so that's kind of where I'm going to focus on today. I'll tell you a little bit about me really briefly. We should all introduce ourselves as father, husband, son, brother. That's what I really am. As I said, I'm also a practicing doc, although I don't see patients very often anymore. And I'm an administrator now. I wear a suit most of the time. And the CMIO, Chief Medical Information Officer, is the workflow expert in the organization. So I do that at the enterprise level, and I'll talk about Trinity Health in a second. And I do that at one of our hospitals, which is really fantastic for me because I get to be at the bedside and be in the ivory tower as well. And I've been very fortunate. I've transitioned my practice into locums. So now I go to all these hospitals all over the country. I try to do 2 or 3 days a month, and it's wonderful because I get to travel the country. I get paid pretty well doing it, and I see all these fantastic processes. I steal theirs, and I share mine as well, and we bring it back. And I also have quite a bit of entrepreneurship, and we can talk about that another time. So I want to talk about Trinity. So Trinity Health is a very large health system. It's the largest faith-based nonprofit health system in the country. We have almost 100 hospitals in 22 states, and 33,000 physicians, and 9,000 of them are actually employed by us, and about 120,000 colleagues. And we have this really cool vision, to be honest. I mean, Dr. Richard Gilfillan, he's our CEO. He came about 4 years ago, and he set this direction. I won't go through it now, but if you have a chance, take a look at this. This is a really noble mission for any healthcare organization, not just a large health system. And the cool thing about Rick is that he was actually my primary care doctor when I was like a little kid, 5, 6 years old. I've never told him that, but I have to remind him of that next time I see him. I'm going to skip over this one. This is just our strengths as a health system. But I do want to talk about this, pain points, and this is where we struggle. And the good thing about this, well, not the good thing, but this is not unique to Trinity. This is unique to pretty much any hospital, and I'm sure Dr. Mukherjee might confirm some of this. The problems vary a little bit, but for the most part, most hospitals and health systems have these problems. And number one is standardization. Now, with the exception of Kaiser, and there are some terrific Sutter Health, there's some great health systems here in California that struggle less with standardization. But the rest of the country, we are really struggling. We have about 100 hospitals, and the way we take care of your stroke or your heart attack or your sepsis or your pneumonia is really pretty different when you go from one of our hospitals to another, even within the same state. In Pennsylvania, we have about 5 hospitals within a 30-mile radius, and each hospital you go to, you'll get good care, but it's different. It varies. The way it's delivered, the timing in which it's delivered varies. They're all pneumonia patients, right? I mean, pneumonia is not that hard to take care of. I mean, I'm talking about simple pneumonia. So that's a problem. So we're trying to, like everybody else, we're trying to be the Walmart of healthcare, right? So we're struggling with that. So the other area is process improvement. We really struggle with process improvement, and that's where you guys come in. We know the theory, we know lean, and all of our management are well trained to do process improvement, but as you know, we need data to be able to do good process improvement, because when we make an intervention, we need to measure to see, did that intervention work or not work? And although we have tons and tons of data, it's very, very hard for us to process that data into something. And again, going back to the sociology, that's a huge part of it, but then we don't have the tools. And that's why I'm so excited to be here, because driverless AI and some of the things that I've seen at H2O, these products are going to help us process that data and make some decisions. Data aggregation, this is another big area, and this goes back to our clinical systems as well. We within Trinity Health have 6 different EHRs. And for those of you that don't know much about EHRs, it's the system that we use to track everything that's going on with our patient. So we have Epic, Cerner, Meditech, Athena, NextGen. It's wild, wild west. Now the good news is 2 weeks ago we made a huge decision to move to Epic. And the truth is, that's a good decision. We'll be unified, and the data will be a little bit easier to manage and record. But it's for me, it's actually big job security, so I'm happy about that. But it will help us a lot, but it's going to create some new problems for us as well, because Epic is not necessarily the most interoperable system that's out there. So change management is another area, and again, my official title is Chief Medical Information Officer, but really I should be called the Chief Change Officer, because every time something needs to change, they call me, and I have to put together a plan and actually make it happen, and I have to twist people's arms sometimes. I've broken a few arms. I've broken my own arm too, maybe more than I should have. But change management is very, very tough. It's very hard to get, especially physicians, to change the way they do things, because we're all very well trained. We all have been pretty smart throughout our life, and we don't like to be told what to do. And I know I am a cowboy, because my way is the only way. And my hospital, if you ask anybody in my hospital, it's the only hospital in the country. There is no other hospital. That's just the way it is. And this is the way not most, but this is the way a lot of hospitals run. They don't think about the way other people do things. It's just the way we do it. Data reporting and dashboarding, this is another area where what work that's going on here can help us. We do a very bad job of sharing data within our own organization. So we have wonderful dashboards and reports for our highest level, executives and kind of the upper level senior vice presidents and those types of roles. But helping the nurse at the bedside or the doctor at the bedside, we don't do a good job of that. Especially our middle managers, they're the ones that are actually trying to make that process improvement happen. And we have a really poor way of getting them the data that they need. So tools that will help us deliver that to them is what we really need to do to advance our objective. And then finally, patient experience and engagement. I told you the story of my dad. That's a story of experience and engagement. He had a very good experience. He was very, very engaged, yet he still could have had a really bad outcome, if he didn't know who to call, on the next day after his care. Okay, so this is what we're actually looking to do going forward. As I said earlier, Epic is going to solve a lot of our problems, and it's going to create a couple of new problems, but Epic is going to be a good thing. I think the large majority of large health systems are trying to decide this. Should we go down this integrated clinically integrated network or completely unified, EHR and completely unified process improvement strategy, or should we take this hybrid approach the way we have been taking for so many years? And it's really, really hard, because these systems are supposed to talk to each other, and they're not. And meaningful use stage 3, which, by the way, I don't know if you know what that is, but meaningful use stage 3 and meaningful use has been renamed so basically it doesn't exist anymore, to something new. And this meaningful use, these dollars have been driving a lot of the change that's been happening. Oh, this thing died. Okay, that's all right. The next area that we're really focused on is clinical standardization, as I talked about earlier, treating that pneumonia patient. And to give you another story, everybody know what sepsis is? So sepsis is a very dangerous infection. It's an overwhelming infection of your body, and it has very high mortality. If you get sepsis, you're at very high risk of dying. And so it's a very serious disease. And so we did a very good thing. We said, you know what, we're going to make sure that we get our septic patients antibiotics within 1 hour of their admission. And that's a very noble thing to do, and we set out to do it. We collected the data, we did all the right things, we looked at the evidence, and we created a process where we were able to give our patients that came into the ED, antibiotics within an hour. Very happy, right? So now it's a month later, and we're looking at our data, and we're looking at all of our data throughout the whole hospital, not just the ED. And we're seeing that there are some patients who are 3, 4, 5 hours before they get their antibiotics. And there was a clear theme. Now, this is a month after we started. It took us a month to collect data, right? Now we're looking at this data. This is not, one person. I mean, I'm looking at the data, but we have 5, 6, 7 other people in this room, right? Really smart people that are really, really busy, right? We're all looking at this data, and we're all scratching our heads, like, why are we not doing the right thing for these patients? And it turns out that these patients were our inpatients. So our ED patients were getting terrific care, antibiotics within an hour. But the inpatients, for some reason, it took us 4 hours sometimes to get them antibiotic. And so we started looking into this, and after, quite a bit of kind of scratching our head and mulling and doing research, this is 15, 20 hours later of man hours, right? We realized that there's a very subtle thing in the way these things are ordered that made this happen. And the subtle thing is that when we order a medication or order anything, we can say Tylenol every 6 hours, or we can say, IV fluid at a rate of, 200 cc's per hour, and that every can be given 2 ways. You can order it, every means Q, the letter Q, so we say Q 6 hours, or you can say Q 6 hours H, and that little H makes a huge difference, because that little H means start it now. And if you don't put the H, it starts it at the next scheduled administration time, which is 9 a.m., 3 p.m., 7 p.m. So if you put the antibiotic in for this septic patient without the H, it's going to be given at the next time. So if we order it at 9:05, that patient's not going to get an antibiotic until 3. right? And if the nurse is not paying attention, if they're busy, if the physicians aren't paying attention, physicians, they don't. Once it's ordered, it's gone. We don't really know. We don't really care sometimes, unfortunately. So this very simple, very sinister issue is what was causing this very severe outcome. And so I bring this up again because this is an informatics problem, right? So this is, again, close to my home. So we have sociology problems, we have clinical systems and informatics problems, and when we just make errors sometimes. We're just careless. That's obviously a problem. Dr. Mukherjee mentioned earlier, accidents and iatrogenic, meaning our fault errors, are the 6th leading cause of death. Almost 100,000 deaths a year. We've improved that a lot, but we are the 6th leading cause of death. We got to do something about this. And again, the only way to really change it, especially the sociologic problems, and I'll end after this little story, is with the data. And this is a story that's very close to my heart because about 16 years ago, I graduated from residency, and I went to my first kind of job. I was on the academic faculty of a teaching hospital, and I was all happy, and everything, life was good. I was getting paid a good wage. I started a brand new service with residents and students and fellows, and it was having a lot of fun and taking good care of patients. But somehow in my mind, I had fantastic training. I was trained at a very good place. But somehow in my mind, I didn't need to wash my hands. I mean, I would wash my hands if I remembered. But when I didn't remember, I said, I'm not going to touch the patient, or I'm not going to touch anything, and it's okay. Because I'm above this rule that you should wash your hands. And that was me right out of residency, right, when you're supposed to be the sharpest. And it took the data, right? So my chief of staff, about 6 months or so, 3 to 6 months after, I kind of realized that I'm too good for this washing hands stuff. Even though it was a question on my boards, my internal medicine board exam had, which of the following is the most effective way to reduce hospital-acquired infections? And the answer was hand washing. I got the board question right. He displayed on a screen just like this that since we went on this hand washing initiative, they put the gel containers all over the place, and they were watching and doing secret shopping, until I saw the data that showed a 50% reduction in our hospital-acquired infections. That's when it clicked for me that, you know what, I better wash my hands. And that's when, and so since then I have a pin that I wear on it's like a punishment for me, to remind me, that says it's okay to ask me if I've washed my hands. So that's a pin that I wear on my white coat. Well, there you go. That's even better. But again, and I think I'm a good guy. I think I'm a nice guy. I think I try to do the right thing for the patient. But if someone like me can think that you don't have to wash your hands, then, and I share this with you because we're all cowboys. We all kind of somehow, for some reason, our system makes us believe that. I think we're better now. I think trainees coming out of residency now are way better than I was when I came out. But we still have a long way to go, and it's only the data that's going to help us get to that point. So I could talk on and on. Another expertise I have is blockchain. I'm not going to talk about that, but I would love to talk to anybody that's interested in blockchain after this. Prashant?